Good morning, teacher and respected respected teacher and my dear friends. So today's topic of discussion will be stroke prevention in asymptomatic carotid artery stenosis. So myself, Dr. Lakshmi, I am a final year SR, and my moderator is Sylaja madam. So I'll be going in the order of we'll first see the definition, then we'll look into the epidemiology of asymptomatic carotid stenosis. Then comes the risk factors, then natural history, then imaging findings, especially the high risk plaque features, and the recent trials and the treatment guidelines which are available. So coming to the definition of asymptomatic carotid stenosis. So asymptomatic carotid artery stenosis is defined as a stenosis of extracranial carotid artery without a history of ipsilateral ischemic stroke or a TIA. And carotid artery stenosis is defined as symptomatic if ischemic symptoms, either ipsilateral eye or the cerebral hemisphere, uh, in the same territory occurred within the last 6 months. And when it is like more than 6 months in that same territory, it is considered as remotely symptomatic carotid artery stenosis. Yes, sir. Sir, any so symptomatic carotid stenosis is any stenosis more than 50 years. So asymptomatic generally in studies is taken as more than 60%. And in symptomatic, it is taken as more than 50%. So coming to the grading of stenosis. So based on the NICET criteria, the carotid artery stenosis is classified as mild when it is 0 to 49% stenosis, moderate is 50 to 69% stenosis, severe is 70 to 99% stenosis, and 100% is complete occlusion. Ma'am, NICET is North American study on the carotid endarterectomy trial. Symptomatic carotid endarterectomy trial. So now coming to the epidemiology of the asymptomatic carotid stenosis. So large vessel atherosclerotic disease is responsible for about 25 to 40% of strokes in Indian population. And intracranial atherosclerosis is more common in Indians than in Caucasians. So it contributes approximately 78.3% of all the large vessel atherosclerotic disease cases. And extracranial carotid atherosclerosis remains a major preventable cause of stroke, which accounts for 10% of stroke cases. Okay. Yes, ma'am, I have. So the severe asymptomatic. Yes, sir. So Indian literature in our institute, there is one study, sir. So severe asymptomatic carotid stenosis, that is more than 70% narrowing, occurs in approximately 0.1 to 3.1% of general population. And the prevalence of severe asymptomatic carotid stenosis increases with age. So severe asymptomatic carotid stenosis, it accounts for 0.7% of the population attributable stroke risk. Although relatively infrequent, ACS contributes to overall burden of ischemic stroke. So traditionally, carotid artery stenosis of more than 50% is considered the etiology for stroke when infarction occurs in its territory. And the recent advancements have shown high risk blocks that is identified by advanced imaging criteria that we will see later of less than 50% can also be the cause of stroke. So now coming to the pathophysiology of the atheroma formation. So the blood flow at the carotid artery bifurcation deviates from the laminar and the unidirectional flow. And there will be flow disturbance that include reduced blood flow velocity, formation of the vortices, and which causes the oscillatory shear stress to the artery wall. And the disturbed flow regions promote endothelial dysfunction, and that promotes the atherosclerotic plaque development. So risk factors such as hyperlipidemia exacerbate this process. So what is the role of hyperlipidemia? So in patients with this atheroma formation, there will be activation of the endothelium. So the endothelial cells, activated endothelial cells, allows the passage of this LDL molecules along with the monocytes. So this LDL molecules will activate the formation of the free radicals in the subendothelial surface, and this ROS escalates the formation of the intercellular adhesion molecules as well as the vascular cell adhesion molecule and the endothelial leukocyte adhesion molecules. So this promotes the monocyte adherence to the vascular endothelial cells. So this monocytes will get converted into the macrophages, and that engulfs the LDL and forms the form cells. So the atherosclerotic plaques begin as the lipid streaks in which lipid material deposits in the intima of the arterial wall, and the macrophages take up this lipid material, forming the form cells. So the excess accumulation of such cells ultimately results in cell lysis and necrosis, leading to the formation of extracellular lipid pools, and that is called the lipid-rich that coalesce to form the lipid-rich necrotic core. So the loose fibrocellular tissue which forms the atherosclerotic lesion often proliferates and intervenes between the necrotic core and the laminal surface, and that forms the fibrous cap. And the plaque neovessels are typically fragile and permeable, predisposing to the intraplaque bleeding. So the lipids also will crystallize. The cholesterol crystals will crystallize and cause injury to the vasovassorum, further causing the that is expansion of intraplaque hemorrhage. Now coming to the risk factors. So advanced age, particularly more than 70 years, hypertension, that is high blood pressure with a longer duration of more than 15 years, increases the risk of that is asymptomatic carotid artery stenosis. Diabetes mellitus, which is long-standing. Smoking, that is heavy smoking, more than 10 pack years. Dyslipidemia, male sex, family history of stroke or cardiovascular disease, and increased serum creatinine levels are associated with increased formation of the asymptomatic carotid stenosis. Family history of stroke or CAD, sir? Male sex is more prominent. I'm not sure. So mostly younger age. Yes, sir. Globally, so this is. So this is an article. Hmm. But in asymptomatic carotid artery stenosis, so as this trial by Weed et al., he looked into the prevalence of asymptomatic carotid artery stenosis in the general population. So it is a meta-analysis, and they have found that the prevalence of moderate asymptomatic carotid artery stenosis ranged from 0.5 in men aged below 50 years and 5.7% in men aged 80 years and above. And for women, this prevalence increased from 0.3 to 4.5. So the prevalence of severe asymptomatic carotid artery stenosis ranged from 0.1 in men below the age of 50 years to 1.7% in men aged 80 years and above. So this is a bar diagram showing the same. So adjusted for smoking, hypertension, hyperlipidemia, and diabetes, we can see that as the age increases, especially in male sex, after 80 years, the prevalence of asymptomatic, so the first image shows the severe asymptomatic carotid stenosis. Second is, first is a moderate and second is a severe asymptomatic carotid artery stenosis. So we can see that as the age increases as well as with the male sex, this the prevalence is increasing. And in the subgroup analysis, the patients who are smokers with hypertension, diabetes, hyperlipidemia, and one of the four, these subtypes are there. So the prevalence of severe stenosis is increased. So now, sir, that is also, sir, it is more. So now coming to the natural history of asymptomatic carotid artery stenosis. So it is associated with an increased risk of stroke in the future as well as cognitive decline. So increased stroke risk and overall 3-year risk of stroke in asymptomatic carotid stenosis is 2.1%, while the risk is 4.5% in cases with severe stenosis. Mm. Yes. Yes, sir. It's a recent observation, sir, but it is coming. I'm quoting the studies. So, so this is an article. So that is by the by Chang et al. On incidence of ischemic stroke in patients with asymptomatic severe carotid stenosis without surgical intervention. So it is a, sir. It is so they have recruited patients. That is a retrospective cohort study, and publication like after 2019, sir. Yes. Yes, sir. Yes. 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 So this is a recent article, sir. After. Yes, sir. Okay, sir. Okay. Yes. Yes. So the incidence of stroke after a mean follow-up of 4.1 years noted 133 ipsilateral strokes in 4,230 arteries of the total 3,737 patients, with a mean annual risk of 0.9% and a 5-year risk of ipsilateral stroke of 4.7%. So this study on the natural history of asymptomatic moderate carotid artery stenosis in a large community-based trial by Rebecca et al. Found that so in out of the 11,614 arteries with moderate stenosis, with a mean follow-up of 5 years. So there were 180 ipsilateral ischemic strokes, and controlling for the death as well as the intervention as competing risks. The cumulative incidence of stroke was 1.2 years at 2% at 5 years and 2% at 10 years. So she found that in this community-based sample of patients with asymptomatic moderate. Yes, ma'am. Yes. Hmm. Yes. Yes. Hmm. Yes. 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 Sir. Yes. Lower. Yes. Yes, sir. Yes. Yes. South Asia, I could. Hmm. Okay. Extract only I have placed. So now coming to the symptomatic carotid stenosis, risk progression and development of symptom study. So this study identified 214 patients and collected data from 249 vessels. And the degree of stenosis that is severe, that is more than 70% upon diagnosis in 92 vessels. And the median length of follow-up was 13 years. So they found that there was a substantial rate of progression of stenosis in patients with asymptomatic carotid artery stenosis over time, despite adequate medical therapy, but progression of stenosis did not increase the risk of ipsilateral TIA or stroke. So there is an increased risk of cognitive decline that can be seen in the asymptomatic carotid artery stenosis patients. So there is a strong link between the stroke as well as the cognitive decline exists. And the memory impairment and executive dysfunction are the usually described cognitive deficits. So initial studies postulated that the occurrence of silent cortical infarction and white matter hyperintensities are the main cause of this cognitive decline. So the recent literature suggests that reduced cerebral perfusion and impaired cerebrovascular reserve as the principal mechanism contributing to cognitive decline in these patients. Now coming to the diagnosis of asymptomatic carotid stenosis. So the modalities we can use are the MR plaque imaging, the CT angiogram, ultrasound, or the contrast enhanced ultrasound. And so now, how to measure carotid stenosis? So in the NACET as well as so that is the North American Symptomatic Carotid Endarterectomy Trial, and the ECST, that is the European Carotid Surgery Trial. Two methods are used. So in the NACET trial, so that is so A is the narrowest ICA diameter. B yes. It's an ACID criteria. Okay. Yes. So the most commonly used method for carotid artery stenosis measurement is the NACET criteria, which is a North American symptomatic carotid endarterectomy trial criteria. So here A is the narrowest ICA diameter, B is the normal diameter cervical ICA, normal distal cervical ICA diameter, C is the estimated original diameter at the site of the most stenosis. So according to the NACET criteria, it is B minus A divided by B. That is normal distal cervical ICA diameter minus the narrowest ICA diameter divided by estimated original diameter at the site of the most stenosis into 100. Okay. Hmm. Okay. Hmm. Carotid sinus. Okay. Okay. Hmm. Yes, sir. So I'll be going from MR carotid plaque imaging. So this is MRI is the standard for carotid artery plaque characterization. So it is best able to differentiate between the soft plaque components such as lipid material and hemorrhage. And 1.2, 1.5 Tesla or 3 Tesla scanners in a resolution of 0.6 millimeter with an effective blood suppression is taken as ideal. And we'll be able to find out the intraplaque hemorrhage, lipid-rich necrotic core, the degree of stenosis, fibrous cap condition, that is the disruption and ulceration, as well as the plaque burden and distribution are measured in MR carotid plaque imaging. Yes, sir. So, so that we can use for the treatment, and we can divide the patients, even like symptomatic or asymptomatic carotid. Sir. Yes, sir. So, looking into the high risk features of the plaque, even if the degree of stenosis is less than 50%, we can like start the patient on the best medical. Yes, sir. Treatment decision. Uh, mm, okay. So now we'll see the high-risk plaque features. So they are the high-risk plaques are prone to rupture, thrombosis, or cerebral embolization leading to TIAs or stroke. So they are characterized by lipid-rich necrotic core, intraplaque hemorrhage, thin fibrous cap that is less than 165 micrometer, and surface ulcers and fissures. So the larger the lipid-rich necrotic core, the higher the risk of cap thinning, fissuring, as well as rupture. And the plaques with lipid necrotic cores, more than 40% of plaque volume is considered high risk. And intraplaque hemorrhage is present in up to 84% of symptomatic carotid stenosis patients. So first we will see the lipid-rich necrotic core. So it is the earliest visible feature of vulnerable plaque. And atherosclerotic plaques begin as lipid streaks in the where the lipid material deposits in the intima of the arterial wall. And on MR imaging, this lipid-rich necrotic core tends to be mildly hypo to mildly hyper to adjacent musculature on the fat suppressed T1 weighted image. They also lack markedly hyperintense signal on heavily weighted T1 weighted images. So this is a representative image. Here in the first image we can see that, so that is a CT angiogram, and this is the lumen, and here we can see the plaque. So the periphery of the plaque is like hyperdense, which means that it is calcified. So in the second image, which is the T1 weighted fat suppressed image, we can see that the calcified image, the calcification is T1 hypo, and there is a iso-intense signal within the plaque. And in the third image, which is the T1 fat saturated cube image, which is the MR plaque image. So it shows the hyperintense signal in the plaque interior, and that is compatible with the lipid-rich necrotic core. So now coming to the intraplaque hemorrhage. So it is caused by the breakdown of the immature neovascularization, which is commonly that we have already seen. So it is significant contributor of the plaque growth, and it is associated with ipsilateral neurological symptoms and increases the risk of future stroke. So it is usually in the T1 weighted MR image, the hemorrhage appears bright due to the methemoglobin blood products. So this is a representative image. And here in the first panel, we can see that it is a axial CT angiogram, and it shows this is the lumen, and here is the atheroma, and the dashed the dotted line represents the calcification, and there is a plaque in the arterial wall. And in the MR, that is T1 axial image, here we can see that the calcification is appearing hypo, and there is T1 hyperintense signal. So that is suggestive of a intraplaque hemorrhage. And image C is that is 1 year later after the best medical treatment, the calcification as well as intraplaque hemorrhage is appearing the same. So CT angio, this is very hypo, so that suggests that it is a very unstable plaque. So next feature is ulceration. High risk feature is ulceration. So it is the defect in the fibrous cap of a plaque, and it is defined as being an indentation, erosion, or fissuring of the luminal surface of the plaque. So these defects are due to weakening of the cap, often due to local inflammation or hemodynamic stress. So ulcerations expose the inner plaque contents of the arterial blood, and this exposure can both rapidly destabilize the plaque and allows the plaque content to embolize to the brain. So ulceration is defined as a cavitation into the plaque measuring at least 1 to 2 millimeter, and it acts as the main source of cerebral microemboli. So next high risk feature is loss of fibrous cap integrity. So the fibrous caps form early during the atherosclerotic plaque development, and it separates the soft plaque components, that is the lipid-rich necrotic core as well as the intraplaque hemorrhage, from the blood in the vessel lumen. So a thick, well-formed cap acts as a protective barrier, and the thickness and the collagen content of the cap are critical determinants of the overall plaque stability. So on MR imaging, a fibrous cap is located along the surface of the plaque and is typically hypointense on TOF image and isointense on T1, and it enhances on the post-contrast image. So in this image, we can see that, so this is the sagittal image, and shows that there is a plaque in the internal carotid artery. And in the axial section, that is in the top image, we can see that, so this is the lumen. The white color is the lumen, and there is a smooth luminal surface. And there is a juxtaluminal band that indicates the fibrous cap. And in the T1 weighted image, it is appearing as hypo. And in the T2, as well as the contrast enhanced image, that is MRI, that is appearing as hyper. So the thick fibrous cap is easier to appreciate as a high intensity band on the contrast image as well as the T2 weighted image. So this is another example. Here we can see that this is a T1 fat saturated axial image. And so here we can see that there is a hyper as well as a hypointense signal. And the second image, so that is again T2. So this is the right ICA as well as the left ICA. And in the post-contrast image, so here the A and B, the hyper signals are the hemorrhage, which is appearing as hypo in the contrast. And the hypo signals in the A and B represents the lipid-rich necrotic core, which enhances on post-contrast. So, so these are the signs of high-risk carotid plaque. So that is, one is the volume or the size of the plaque, then the hemorrhage, intraplaque hemorrhage. So ulceration, irregularity, lipid-rich necrotic core, neovascularity, as well as loss of fibrous cap. So in this study on the carotid plaque with high-risk features in embolic stroke of undetermined source, so by Joseph et al. So 323 participants were included, and they found that plaques with high-risk features are 5 times more prone in more prevalent in the ipsilateral compared to the contralateral carotid in ESUS, suggesting a relationship to the stroke risk. And in this study, that is on the recurrent, that is carotid plaque characterization, and the recurrent ischemic stroke study, that is the plaque at risk study, Paris study. So here they found that the intraplaque hemorrhage and the total plaque volume were significant predictors of recurrent ipsilateral ischemic stroke in patients with carotid stenosis less than 70%, with a hazard ratio of 2.12 for intraplaque hemorrhage and 1.07 per 100 microliter increase in the plaque volume. So now coming to the asymptomatic patients. So this study by Navneet Singh et al. On moderate carotid artery stenosis and MR imaging, they found that univariate Cox regression analysis confirmed an MR depicted the intraplaque hemorrhage was associated with an increased risk of cerebrovascular event with a hazard ratio of 3.59 with a 95% confidence interval. So, and this is another study that studied the predictors of the surface disruption of the MR imaging in asymptomatic carotid stenosis. They found that the surface disruption is directly proportional to the okay. So now coming to the CT angiography. So that enables a fast and accurate acquisition of vascular structures with minimal discomfort. The plaque features such as intraplaque hemorrhage, lipid core, and calcification can be identified in CT angiography better. So here in this image, we can see that so there is a plaque which is calcified, and here we can see that the outer surface of the plaque is calcified, and it has a eggshell type of configuration. And here in the figure A, it represents a thrombus, and here in the B, we can see there is the plaque surface is not uniform. That indicates an ulceration. So now coming to ultrasound, it is a first-line imaging modality in the evaluation of the carotid artery plaques, and it's a simple, inexpensive, widely available modality. And in the B mode, high lipid content and the intraplaque hemorrhage appears echolucent, while calcium and the fibrous tissue appears echogenic. So it cannot reliably discriminate the lipid from the intraplaque hemorrhage because of a substantial overlap in their echostructure. So this representative image of the B mode ultrasound shows there is a common carotid artery showing the soft echolucent plaque as well as the hard echogenic plaque. So okay. So in the contrast enhanced ultrasound, the plaque enhancement in the contrast enhanced ultrasound correlates with a greater neovascularization at the histology. So here in this image, we can see that the arrows denotes the microbubbles within the neovessels in a plaque. So next is the TCD. The contrast enhancement corresponds with the neovascularization. That is the not shows. Okay, and next is the TCD, that is transcranial Doppler ultrasonography. So here the non-invasive method, so it is a non-invasive method to assess the cerebral blood flow. This detects the microembolic signals in patients with carotid stenosis. The TCD can help identify a subset of patients with at a higher risk by detecting this cerebral microemboli, that is MES signals in the middle cerebral artery. And the presence of these signals suggests a more unstable plaque, conferring a higher risk of future stroke. So in the microemboli detection, what we see is hits, that is high intensity transient signals that represent a 1 hour. Significant. So minimum of 1 hour recording is needed, and even a one hit is significant. So this is a representative image, and here in the upper channel, this is the M mode image of the embolus in the middle cerebral artery, and in the lower panel we can see that it shows the hits, that is high intensity transit signal in the Doppler channel. So in the study, that is the asymptomatic embolization for the prediction of stroke in the asymptomatic carotid emboli study, that is the ACES study, which got published in the Lancet in 2010. They found that detection of asymptomatic embolization on TCD can be used to identify patients with asymptomatic carotid stenosis who are at higher risk of stroke and transient TIA, and also those with a low absolute stroke risk. So this study showed that by David Spence et al. Showed that the absence of the patients with microemboli were much more likely to have microemboli 1 year later, and were more likely to have a stroke during the first 1 year of follow-up. Yes. 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 So this study by Abbott et al., which looked into, no, ma'am, actually microemboli detection is favorable. That is the future risk of. Uh, uh, yes, ma'am. So, so this study by Abbott et al. Looked into the variability in transcranial Doppler detection of embolic signals, and they found that the embolism associated with asymptomatic carotid stenosis showed a circadian variation with the highest rate at 4 to 6 hours before midday, that is during morning hours. I am not sure. I'm not sure. Mechanism is not sure. They have looked into the circadian variation, and they have found that the chances of detecting microemboli is more during the morning hours than the evening. So because there will be a like BP fluctuation. Okay. So now the another thing that we can measure with TCD is the cerebrovascular reactivity. It measures the vascular reserve downstream of a stenotic vessel. So the chronic downstream vessels to dilate maximally to maintain a normal blood flow. And a maximally dilated circulation will not respond to further vasodilatory stimuli and is at risk for hypoperfusion impact. So in the TCD, we assess the CVR by monitoring the middle cerebral artery mean flow velocity before and after a vasodilatory challenge. So the common vasodilatory challenge include either breath holding or inhalation of carbon dioxide. So the normal CVR shows increased mean flow velocities after vasodilatory challenge, reflecting vasodilatation and increased flow. And the poor CVR is indicated when the MFV remains similar before and after the vasodilatory stimulus. So now the imaging biomarkers associated with an increased risk of stroke include the silent infarction on CT brain. So this article by Pinney et al., they found that in a multivariate analysis, the contralesional carotid occlusion and severity of stenosis were independently associated with the silent brain infarction. And silent brain infarction was present in 8% of asymptomatic carotid stenosis, and it is significantly associated with contralateral carotid occlusion and severity of the carotid stenosis. So the second imaging biomarker that can be used is the stenosis progression with BMT. So progression of carotid stenosis is about 20% of patients, and it occurs maximum in the first 3 years, and then by 8 years it becomes zero. So male gender, hypertension, coronary artery disease, age, plaque area, and elevated creatinine were associated with plaque progression. And the risk of future stroke is twice in people with the progression of stenosis. Yes. 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 Okay. So the patients on best medical therapy, we have to follow up with ultrasound of the neck every 6 months to look for the stenosis progression. And so the next imaging biomarkers are the intraplaque hemorrhage on MRI, intraplaque hemorrhage, lipid-rich necrotic core, thinning as well as rupture of the fibrous cap. This we have seen. And next is the spontaneous embolization of PCD and the plaque lucency on the duplex ultrasound. So ulcerated plaque, severe stenosis, impaired cerebrovascular reserve, and the contralateral stroke or TIA were also associated with increased stroke risk. So now the question is, should we treat the patients with asymptomatic carotid stenosis? So this is, we have already seen that the future risk of stroke is high, as well as in the patients with asymptomatic carotid stenosis. So they have a significantly increased risk of CAD. So this study by Norris et al. In 1991, he assessed the vascular risk of asymptomatic carotid stenosis and found that with stenosis less than 75%, the stroke rate is negligible. Whereas the combined risk of cardiac ischemia and vascular death is as high as 9.9%. And with stenosis more than 75%, combined TIA and stroke rate was 10.5%, with 75% of events ipsilateral to the stenosed artery. And this is a study from our own institute, and it looked into the risk of stroke and cardiac events in medically treated asymptomatic patients. So here, all the patients with TIA or minor stroke who had undergone a vessel imaging as part of their evaluation, and the patients who, with coronary artery disease who had undergone vessel imaging before the cardiac intervention were screened for the presence of asymptomatic carotid stenosis. And out of the 1,800 patients, 92 patients had this asymptomatic carotid stenosis, having 50 to 90% stenosis. That is significant. And 63 had TIA and minor stroke, 29 had coronary artery disease, and of whom 7 patients had bilateral ACS. So they concluded that although the risk of stroke in patients with ACS is low, acute coronary events and the vascular death were significant. So this highlights the importance of intensive risk factor modification to induce adverse cardiovascular event in ACS rather than revascularization of the carotid stenosis. So now how should we treat asymptomatic carotid stenosis patients? So what does the trials say? So this is the first study, which is the Veterans Affairs Cooperative Study Group. And it got published in 1993. So they recruited patients, that is 444 men, and they were randomly that is assigned to, yes, yes. So in this study, they have found that the combined incidence of ipsilateral neurological event was 8% in the surgical group versus 20% in the medically treated group, which is uh, um, like statistically significant. And they concluded that carotid endarterectomy reduced the overall incidence of ipsilateral neurological event. Yes, ma'am. So next study is the ECAS trial. Yes, sir. Yes. So next is the ACAS trial, which is the asymptomatic carotid atherosclerotic trial, which was a prospective randomized multi-center trial. So they also found that after median follow-up of 2.7 years, with 4,657 patient years, the aggregate risk over 5 years for ipsilateral stroke and any perioperative stroke or death was estimated to be 5.1% for the surgical group versus 11% for the medically treated group. So next came the ACST trial, which is the asymptomatic carotid stenosis, that is carotid endarterectomy for the asymptomatic stenosis trial. So so they recruited the patients from 1993 to 2003, and total of 3,120 asymptomatic patients were allocated into two arms. So one is the like okay yes uh, yes the previous study. Yes. So, carotid endarterectomy cause some risk of perioperative stroke or death, but allocation to immediate carotid endarterectomy almost halved the non-perioperative stroke rate over the next 10 years. No. So next is the ACST2 trial. So here they have compared between the carotid artery stenting versus carotid artery stenosis in asymptomatic patients. And they found that the serious complications are similarly uncommon after a competent carotid artery stenting and carotid endarterectomy. So none is, so both these can be used, can be considered in patients with asymptomatic carotid stenosis. So uh, these are the medical treatment used in the previous RCTs. So in the VAST study, so aspirin 650 mg twice per day or 325 mg per day dose was used. And in the ACAS trial, aspirin 325 mg per day. That is in the 1990s trial, aspirin 325 mg per day was used. And but they have considered the other risk factors like hypertension, diabetes, abnormal lipid levels, excessive alcohol, as well as tobacco use. And in the 2000s, that is in the ACST trial, the along with the antiplatelets, the other risk factor control were also considered. So the earlier RCTs did not use a high intensity statin, a strict target of blood pressure, blood sugar, and the lipid levels. So that may be the reason why they have found that the medical, that is the medically treated arm, is like less benefited from the surgical arm. So then comes the TNT trial. So that is the intensive lipid lowering with atorvastatin in patients with a stable. Okay. So this is a yes, ma'am, it is coming. This is on statins. Okay. So next is the space 2 trial. So which is the carotid endarterectomy or stenting versus the best medical. Yes. 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 So both the carotid. Yeah. Yes. 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 Not superior. Yes. 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 So in this phase 2 trial, they found that both carotid endarterectomy or stenting were not shown to be superior to the best medical management, both for stroke or the death in 30 days, as well as the ipsilateral stroke at 5 years. So this trial done after the widespread use of statin and other best medical management practices did not show superiority of the revascularization over the best medical therapy. So in the next trial, which is the ECST trial, yes, this is a 2-year interim analysis. They also found that OMT there is no evidence for a benefit of revascularization in addition to OMT. So the latest trial is the CREST-2 trial, which is the carotid revascularization and the medical management for asymptomatic carotid stenosis. They also best medical management. Yes. Yes. So in the ECST trial, in this ECST trial, even though the patients had, that is patients with symptomatic as well as asymptomatic carotid stenosis, more than 50%, they have further classified, grouped them based on the carotid artery risk score. That is, patients with less than 20% may not require the stenting. So even if they are symptomatic. So they found that, what we can, the message that we get from this study is, so we can individualize the treatment in each patient, whether it is like, even if it is symptomatic, we can look for the other plaque characteristics, and the treatment decisions can be made accordingly. So, sir, just going to. So now coming to the. So this is the most recent, sir. This is the CREST-2 trial. So this they have not published it. So they have Hmm. Yes, sir. Hmm. Yes. So in the yes. So so these are the
You have elaborated many ways of identifying black carrots.
yes, sir.
Do you have any study documenting that these plants, health plants, really go for the smoke compared to the not like the first?
Yes.
Or the iris plant is underwent the interventions are more protective than having study doing that.
Right.
In the study demonstrating that the iris plant is really convenience compared to the lower resistance.
Yes, sir. I've shown in that MRI. It is. So there are various trials, and they have looked into the this Parks. I see.
So that is that in the patients who are going to be unstable, having unstable plan,
Yes, sir.
the surgery or intervention better than do we have any study?
Sir, in the carotid, that is microemboli study. So that is microemboli is related to the unstable plaque. So in that they have found that in the patients that is without a microemboli, best medical management is better than the carotid endarterectomy. Nice. Yes. Yes. Yes, sir.
Substantiate in any price doing that people with unstable plaque more than or they are more likely to benefit out of that.
So in the recent ECST2 trial, they have identified the high risk plaque features. That is, the CAR score is there, sir. So that is, so in that they have found that the patients with a mild to moderate risk of, that is mild to moderate features of this carotid stenosis. So the patient will benefit from the best medical management, even though the stenosis is more than 50%. So we have to look into the CAR score.
Even if there are high risk features in the plaque, there is no application for.
So intervention is best medical therapy, sir. So these are the, with the recent trials, we like in the patients with a high risk plaque, we can go for a best medical. Yes, sir.
But will you allocate something for that?
Sir, it is like there is no recommendation for a high risk plaque, sir, but like expert opinions are there. That is in 2021, Lancet published one expert opinion, and in that they are telling that patients that is more than 50% of asymptomatic carotid stenosis. That is one thing is we have to assess the patient based on the percentage of stenosis. Second is whether the perioperative risk is less than 3%. That is in the frail patients, that is friability, as well as the 5-year, that is expectancy, life expectancy. Yes. Individualized. Yes. Yes. Mm. Yes. Yes. Image. Yes. 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 Mm. So it is individuals. Yes. Mm. Yes. Stroke. Yes. So, mm, so,
If you have like that,
yes, sir.
looking for that,
Mm.
and then you find that there is 90%
Sir, one thing is initiate on the best medical therapy. So that is the first thing we can do. And then we can, yes, sir. Then we can discuss with the patient as well as the family. Yes, sir. Silent infarct in the same territory of that. So that is a high risk feature for a future stroke. So better to go for a like a revascular. Yes, sir. Yes. Continue on the best medical therapy. So, concluding, further studies to identify more robust clinical, radiological, and other biomarkers are needed of the hour, and large studies to define and study the effect of optimal best medical therapy should be undertaken. And RCTs comparing the current BMTs with the current technologically advanced revascularization strategies should also be planned. Thank you.